طلبة الماجستير نتكلم عن موضوع الهير and nail disorders as I told you before. So here the first slide is the learning objectives, which include the concept and describe different common hair and nail conditions as you see them in your clinical practice. Number 3, describe hair and nail lesion in systemic disease, which is very important for you since you are not a dermatologist but you are a pediatrician dealing with many diseases that are associated with skin manifestation, which are the hair and nail, which are a component of the skin. Number 4, outline some form of the treatment. Next slide you see here some nail disorder in children from the age of birth to 5 years. You see the common problem in the newborn, which would include the following: koilonychia, transient physiological onychoschisia, traumatic punctate leukoonychia, pseudo hypertrophy of the hallux. Pathological condition in the newborn, you may see clubbing, which usually is familial and inherited because the acquired need several months to develop, nail patella syndrome, and multiple ingrown finger nail. In infant 1 month to 1 year, transient light brown or ochre pigmentation. Whose line of the fingernail is physiological. Among pathological conditions, epidermal dysplasia. Toddler, as you see, 1 to 3 years, punctate leukoonychia, and pitting, which is physiological. You see here abnormal condition like diskeratosis congenita, epidermolysis bullosa, curved nail of the fourth toe, onychia and micronychia and others. Preschool age, chevron or herringbone nail, pachyonychia congenita, acute paronychia and others called abnormalities in this age group. Next slide you see here normal finding in these children. This one is neonate, normal fingernail, you see here, 4 days old, and here is normal fingernail and toes and 4.5 years old child. Next slide, here you see nail diseases which may be congenital or hereditary, and signs are present at birth or may be acquired and appear later during life of the child. So this is the koilonychia, and my son is spooning the anterior and lateral view. Nail abnormalities are a feature of many genodermatosis, an inherited condition. About 75% of congenital syndrome are associated with nail abnormalities. It may be hereditary, acquired, or genetic, as I told you. So frequently idiopathic in the newborn, especially on the big toe, where it is present in 33% of cases, as a normal variant, spontaneously resoluted. When the nail plate thickens after the age of 9 years, it may be manifestation of inflammatory skin disease, such as psoriasis or lichen planus, or secondary systemic disease like iron deficiency anemia and inflammatory Vincent syndrome, intestinal storage disorder, or endocrine abnormalities. Here we see transient physiological onychoschisia, where there is transverse and lamellar splitting at the free edge of the nail, especially the big toe and the thumb, which may be seen in early infancy, around 30% of the newborn, and this apparent hypertrophy doesn't need any treatment because of the transitory alteration. You should know something about the composition of the nail. Here you see there is a protein, water, and lipid, but trace elements are also important, which include zinc, copper, iron, and magnesium. Here there is the linear nail growth, and this is the nail plate, proximal nail fold, and these are the days of growth of the nail from the proximal nail fold, and this is this white colored area called lanula. Here you see the longitudinal section of the distal digit showing the different components of the nail apparatus. This is the proximal nail fold, this is the cuticle, and the white area is lanula. Here the distal groove, this is the hyponychium, and this is the eponychium. Here in this area, this is the matrix area, the green and the orange or rose color. This is the distal and the proximal matrix of the nail. Now we come to some pathological condition that may be seen in the nail. Here you may see traumatic punctate leukonychia. There is some white spot on the smooth surface of the nail plate, especially in the neonate. It is possible to observe the presence of punctate leukonychia caused by alteration or imperfection in the proximal part of the matrix. Sometimes there is apparent hypertrophy of the proximal and lateral nail fold, pseudo-hypertrophy of the hallux present in 73% of the newborn, around 3/4, accentuated by the presence of cholynychia and triangular shape of the nail plate. The thin nail plate, this shape induces a minor force pushing down the lateral fold, which reacts by overlapping but with no sign of inflammation. Clubbing, most of you show clubbing of the finger, and you know the common condition associated with clubbing, especially cardiac and respiratory. But 80% of cases are associated with pulmonary diseases. Congenital clubbing or familial may be present, or may be associated with cardiac disorder, sometime at birth present, which is physiological. Here you see a condition called nail patella syndrome. Mostly the nail and patella are affected, but another organ, especially renal or skeletal, may be involved. So you see here the nail are affected badly with some discoloration, and this is longitudinal ridge, hypoplastic nail, posterior iliac horn, presence of iliac horn here, and there is some changes in the knees and elbow joints. Also there may be renal damage with the proteinuria, hematuria, and hypertension. Sometimes in severe cases nephrotic syndrome. So all these are involved. The patella is hypoplastic or absent patella. Here some pigmentary abnormalities of the nail, the transient light brown or ochre pigmentation of the proximal nail fold. This is the nail fold here. More typical of darker skinned infant is physiological melanic pigmentation, may appear in the first 6 months of life, persists for a few months, and characterized by a regular reticular pattern located only in the periangual tissue. Periangual. without involvement of the cuticle or the nail unit. Very angular. Boo's line at 4 weeks of life, the mutant and disappear with growth before 14 weeks. It describes a single transverse depression of the fingernail. Here we see a condition called ectodermal dysplasia. Ectodermal dysplasia is a complex of group of congenital disorders that include 170 to 200 distinct conditions characterized by abnormal development in 2 or more ectodermal tissues, especially hair, nail, teeth, and sweaty glands. Non-specific, they include hypoplasia. You see here hypoplasia of the nail with subungual hyperkeratosis, anonychia, absent nail, micronychia, thinning, and onycholysis. Here you see punctate. These are white areas here and here due to trauma to the distal matrix. Milky white discolorations located within the nail plate and resulting from presence of foci or hyperkeratotic cells. Can be punctate or transverse. Punctate leukonychia is typical of several fingernails. Nail pitting. There are small depression of the nail plate surface, commonly seen in psoriasis and alopecia areata. Pits of psoriasis are large, deep, and irregular in shape and size, while the pits of alopecia areata are regular in shape, size, and distribution. Here, a condition called dyskeratosis congenita. This is a hereditary disorder. There is dystrophy of the nail with leukokeratosis of the oral mucosa, extensive net-like pigmentation of the skin is typical triad of symptoms. So oral mucosa, extensive net-like pigmentation of the skin, and leukokeratosis with dystrophy of the nail. Nail changes are the first manifestation appear during early childhood, and they lead to splitting, dystrophy, shedding of the nail, as you see here. Sometimes including other abnormalities in the teeth, GIT, genitourinary, neurological, ophthalmologic, pulmonary, skeletal has been described. Bone marrow failure may develop in 50 to 90% of cases. These are chest changes. And this is the skin pigmentation, reticular or net-like pigmentation. An interesting inherited condition which is called epidermolysis bullosa, a group of genetic disorder, autosomal recessive or dominant. Marked mechanical fragility of the epithelial tissue is the most important feature. Non-scarring, blistering. You see blistering here, blistering in the mucosa. Here the newborn with the problem. After minor trauma due to anchoring defect between the epidermis and dermis. This basement membrane defect or defect in the dermis give epidermolysis bullosa simplex. The basement membrane zone defect, integrine affected, so the junctional type of epidermolysis bullosa, or in the dermis, dystrophic epidermolysis bullosa. So we have 4 types here of the epidermolysis bullosa: simplex, junctional, dystrophic, and Kindler syndrome, which is both severe. It can involve the eye, nose, ear, upper airway, genitourinary tract, and GIT. So this is the real patient. I saw it previously. This girl, there is affection of the hair fall. There is skin, nail, mucous membrane affected, but fortunately still alive. So the GIT, especially the esophagus, is affected. The nail dystrophy can be permanent with anonychia, progressive hyperkeratosis, with onychogryphosis, nail thickening, and burrowed peak nail deformity in adult life. Here you may see congenital malalignment of the hallux. Probably sometime you may see it in acquired because of unfitted shoes. They cause malalignment, curvature of this picto with affection of the nail, malalignment. You see congenital anonychia in 1-year-old child. You see hypoplastic or sometimes absent nail. Can be congenital associated with other deformities describing autosomal recessive inheritance. It can also acquire after a great event, inducing the complete destruction of the affected area, such as blisters of epidermolysis bullosa. There is a condition called finger sucking. Frequent infants suck one finger, usually the thumb, even if they don't visit to the doctor. Thumb sucking is a common childhood habit that may increase microbial exposure. 31% of children are frequently thumb suckers at more than 1 year of age. Now we come to the hair disorders, which is very important, is hair loss. So normal loss 100 hair per day, not noticeable among 100,000 we have, grows 1 centimeter per month. Permanent hair loss, especially in androgenic alopecia and scarring alopecia. Sometimes there is temporary hair loss, especially in phases of growth, telogene effluvium, traction alopecia, and alopecia areata. In case of alopecia areata, usually it's autoimmune disease, the cause is unknown, possibly triggered by viral or other infection in predisposed population. Usually the condition is temporary and can be recurrent loss. There is remission and relapse. So this child has alopecia areata like this one. After a treatment everything is okay, or sometimes spontaneous recovery. In males there's androgenic alopecia. You see this area, front area, sometimes in the middle and back, this one and this one. So this is called male pattern alopecia, which is a physiological reaction induced by androgen in genetically predisposed male. Gradual recession of hair on central scalp and frontotemporal region. In the female we may have also female pattern alopecia. Central scalp hair loss with retention of normal hairline. Studies suggest adrenal dysfunction as one possible cause. Androgenic alopecia treatment, you may use minoxidil, medication, solution or shampoo or spray. Ideal in men under 30, have been losing hair for less than 5 years. Approximately 1/3 of these patients will regrow hair long enough to be cut or combed. So you may use this medication. May stop or retard the progression. Effective in female pattern as well. The other type of alopecia is the cicatricial or scarring. It's a rare condition. Inflammation, damage, and scars the hair follicle, causing permanent hair loss. Patchy hair loss can be associated with a slight itching or pain, cause unknown, and can be associated with lupus or lichen planus. Alopecia areata, rapid onset of total hair loss and sharply defined, usually round area, diagnosed by observation. Most patients are young. Regrowth in 1 to 4 months usually, cause unknown. Whole scalp may be involved, called alopecia totalis. Whole body involved, we call it universalis. The treatment option of alopecia areata, first of all, is observation. Just observation is okay. Sometimes because of the child or patient is anxious and worried about this problem, so you may use intralesional injection with steroid. Sometimes use systemic steroid or PUVA, soraline photosensitizing agent plus UV light, and sometimes you may use minoxidil as hair stimulant. You may have condition common in children which is related with the abnormal psychology called trichotillomania, the act of manual removing of hair as irresistible urge to pull the hair and a sense of relief after the hair has been plucked. Thin and irregular pattern hair loss. Thin irregular pattern cases result spontaneously. Treatment aimed at behavioral modification of the child. So to diagnose the cause of hair loss, you have to take history, especially drugs and diet restriction, vitamin A deficiency, illnesses, especially febrile illnesses, anemia, recent childbirth, thyroid status may be involved, time of onset and duration, abrupt telogen or gradual in energy phase or localized. Opposite of hair loss is hirsutism. Hirsutism, appearance of excessive coarse hair in pattern not normal in female, may be a sign of endocrine disorder, most cases mediated by androgen, which originate in adrenal or ovaries in female. Many patients have no physiological cause. So this is a syndrome, coronilla di Lange. This is excessive steroid, and this is infant of diabetic mother with hypertrichosis. Among etiologies of hirsutism, polycystic ovarian syndrome, endocrine disorder involving the abnormal hormonal level, irregular menses, infertility, and ovarian cyst. Cushing disease, overproduction of cortisol from pituitary gland, and ovarian or adrenal gland tumor. So the differential diagnosis of hirsutism may include the following. Hypertrichosis hair would be distributed in a generalized non-sexual pattern, often due to use of medication like phenytoin, glucocorticoid, minoxidil, cyclosporine, or sometimes idiopathic familial trait more common in some ethnic groups. They have more hairy skin. Various causes of hyperandrogenism, polycystic ovary syndrome most common. Insulin resistance lead to increased insulin level. Insulin stimulates ovarian theca cell to produce more androgen. Congenital hyperplasia in a classical, because the classical is early. Androgen secreting tumor would see rapid rate of hair growth and evidence of virilization, clitoromegaly, and increased muscularity. Cushing syndrome, hyperthecosis, increased production of testosterone from theca cell of the ovaries, hyperprolactinemia, acromegaly, thyroid dysfunction, obesity or insulin resistance, and idiopathic hyperandrogenism. Sometimes idiopathic production of androgen precursor lead to increased androgen level, which lead to. In physical examination, you check for sign of virilization, muscularization, and hair presence. Pelvic examination for ovarian tumor, pelvic mass. Abdomen for adrenal tumor also. And laboratory evaluation for hormonal level, check for hypercortisone and other hormone. Ovarian ultrasound, you check for any abnormality in the ovaries, and treatment aimed at the underlying cause. Thank you very much.